Hello, everyone, and welcome to the Simpler Education Series webinar. Today's webinar is titled Plugging the Leaks, Maximizing Reimbursement While Managing Change, with speakers Donna Goestenkors and Larry DeHoyos. Before I introduce Donna and Larry, I would love to do some housekeeping and ensure that audio is working for everyone. So if a few of you wouldn't mind chatting in, I would really appreciate that to make sure we're coming through loud and clear. Awesome. I'm seeing tons of I can hear yous and loud and clear. It's beautiful. Okay, so now I have the pleasure to introduce our presenters for today. First up, Donna Goestenkors. Donna is a consultant, speaker, author, educator, and mentor with more than 40 years of knowledge and experience in the medical staff services industry. She has expertise in virtually every type of healthcare organization, including hospital systems, medical staff services departments, CVOs, managed care organizations, and more. And we also have Larry DeHoyos with us today. Larry is a director of credentialing and payer enrollment with the U.S. Dermatology Partners in Dallas, Texas. Larry oversees the organization's health plan enrollment and provider credentialing functions for its 106 sites across the country. Larry's focus includes centralizing systems and workflows and collaborating to help mitigate enrollment claim denials. So as a quick note, you can access today's presentation, any handouts, as well as your NAMS CEU certificate in the GoToWebinar control panel. We will also send you an email by the end of the week with a link to the recording of today's webcast, its slides, and another copy of your CEU certificate. So at this point, everyone can hear us and we're getting geared up. So take it away, Donna and Larry.
Great. Thank you, Steph. And hello, everyone. Larry and I are actually on the same slide, so I want to formally welcome all of our attendees. And Larry and I were talking just before this session began, describing how many sessions we've done over this past month on payer enrollment. Now, it's been a while since we've presented a payer enrollment session with Simpler, but the topic for today is really kind of cutting edge from our perspective. We oftentimes describe introductory, intermediate, and advanced process things, but right now, we wanted to share with you strategies on how we can help you help your organizations identify where these revenue leaks are occurring so we can then tighten up our process. So we have a lot of information to get to today. And with that, I'm going to ask Larry from primarily a voice recognition, if you wouldn't mind just saying a few welcoming words to our listeners today.
Hello, everyone. Just wanted to say thank you. Thank you for giving us the opportunity. I hope to share some good information with you and definitely look forward to talking with you over this next hour. Thank you.
Perfect. Well, every session that we do always comes from a need that has been expressed to us from the industry. Payer enrollment is such a commodity of needs and wants. There are so many, I should say, there is such a lack of resources out there for our colleagues to really validate the processes that they've been using. So we do appreciate and we recognize, that without your participation in events such as this and without the sponsorship of Simpler and NAMS offering these CEUs, these types of programs wouldn't be possible. So it really is a joint effort. What are we going to cover in today's session? Well, really, it starts off with 3 simple steps. We really want to describe to you what Larry and I believe may be a new MSP competence or competency that we need to be aware of so we can, again, better meet the needs of our organizations. We're going to describe to you what really happens with revenue leakage, where these things are occurring, and how our processes and the better control we put into our processes can sort of plug those leaks. We're going to describe for you 3 steps that the payer enrollment specialists that so many of you are on the phone can do to prevent that leakage. So again, it's about tightening up our processes. And then we're going to explain 4 process improvement steps that can be taken within your workflow, your current workflow, that you can analyze and assess when you go back to the workplace and use this PowerPoint sort of as an educational tool for yourself. So as we always do, let's prepare ourselves to really stretch our minds and open our knowledge in understanding payer enrollment and how, again, we can maximize that revenue coming into your organization. So this graphic, Larry and I love this graphic because we really are giving this program today to help you, to help your organization plug those money leaks. When we talk about money leaks, when we talk about payer enrollment, it really is a higher profile of what the industry is referring to revenue cycle management. Now, I come originally from the credentialing world, right? Medical staff services departments, CBOs. So I view myself as being a credentialing expert. And in all of my days, and I've been in this industry for over 40 years, I never thought that I would have to know anything about how money's being collected within an organization. But that's why Larry and I are introducing this slide, because it's sort of like when we in medical staff services departments had to work more collaboratively with our quality representatives. And now how medical staff quality really is such an important facet in the world of credentialing. We have to be knowledgeable about what's being collected, how it's being collected. We don't necessarily have to be the analyzers of that data from a detail perspective, but we have to have a working knowledge of how the process works to be sure that we're providing the medical staff leaders with accurate information. Well, Larry is the expert in the payer enrollment component. And so the natural outreach is just like credentialing. We've had to open up our stakeholder vision to welcome those quality individuals and payer enrollment specialists into what we viewed as our traditional roles. And we're asking now for the payer enrollment specialists to do the same by looking at what they do more broadly. What you're doing as payer enrollment specialists is indeed very, very important, but we have to understand the bigger picture of how all of these things fit together. So very quickly, what starts really at the beginning? And it's really to understand, what does revenue cycle management really mean? Another reference to revenue cycle management is RCM. It really is the process of identifying, collecting, and managing that organization's revenue from the payers so they can get paid for the services that they're providing. How an organization handles the finances and processes associated with all of the many steps that involve a patient care from the very point of entry to the completion of the billing cycle. And understanding that those 2 process components is essential to be sure that the organization maintains a strong financial bottom line. They have to be financially successful. Otherwise, that organization, that practice is no longer going to be able to operate and provide the patient care that we know our communities need. And that's why the role of the MSP, whether you're doing credentialing, payer enrollment, or a combination of both, that's why we believe that we need to understand what revenue cycle management means. Now, when Larry and I were doing research, and again, Larry's the expert, but when we were doing research, there's all kinds of models and theories about revenue cycle management, sometimes as many as 18 steps. What Larry and I did was select something that was very self-explanatory and much easier to follow. So Larry, from here, I'd love for you to please introduce our listeners to this particular model, because we believe that it really encapsulates the essence of revenue cycle management. Larry?
Sure, Donna, thank you. This diagram here basically explains what a cycle in revenue, the revenue cycle management experience kind of entails. It really, you won't see where payer enrollment starts here, because the revenue cycle kind of starts at where the patient enters the office or enters the clinic. As we say in payer enrollment kind of is the gatekeeper to revenue cycle, because if it wasn't for payer enrollment, the revenue cycle wouldn't be able to start. So when we go into before the visit, the eligibility check at the very top of the diagram is where the eligibility check and demographic verification would start. And that's kind of what is reliant upon the payer enrollment process. And that's where we rely on what Donna and I are considering a possibility of the new MSP competency of revenue cycle management, introducing this whole concept of revenue cycle into our competencies nowadays, as it's a new and introduced role as being into credentialing. So as an enrollment specialist, we're now responsible to be doing these responsibilities in our roles. Then it goes into collections, goes into claim creation, correcting denials, claim follow-up, and these are all responsibilities now that are relying upon payer enrollment specialists. So then we want to go ahead and take a step back now to start talking about really wanting to resolve these revenue leakages. So in the industry as a whole, what happens is that companies are trying to save money. They're trying to look at where these leakages are happening. So what happens is that these industries are trying to consolidate, mergers and acquisitions are happening, and the reason why we put in here tomorrow is always different. So industries are changing, health systems are merging with others, they're getting larger, and you're getting small mom and pop clinics are vanishing. And, the healthcare industry is a constant evolving industry, and healthcare service organizations are required to follow suit if they really want to survive. So how are they responding? Well, through mergers and acquisitions. Just in 2017, we saw 115 mergers in just 11 transactions totaling $1 billion, and they change. In 2018, there were 90 mergers in health systems with 13 transactions, $2 billion. And just last year in 2019, we had 46 mergers at the close of quarter two, so just half of the year. There was a large merger with Bristol Myers, acquired Celogen in quarter one for $74 billion. Now, I put in there, was that a driving factor? And it was basically to reduce overhead. And, things that kind of drive those things is making health systems larger, that's adding services, growing footprints across regions, centralizing systems. Specifically with our own industry, we have larger CVOs. We go into the CVO type realm. We start centralizing. We outsource. We have vendor products that are starting to merge, are starting to grow, are starting to increase their footprint out internationally. We're adding service lines. We're starting to become more commercialized. And then we're also starting to go remote. We're starting to become more mobilized. So there's a lot of different ways that our own healthcare industry is determining itself. And we're also starting to find ways that things are becoming more error driven. There's a lot more errors out there, and that's why there's a lot more leakage. So what do we need to do, and what do we need to do to find those things? And that's why we're here to kind of help you and kind of analyze and what we need to fix those things. So changes is inevitable in healthcare, and no matter when, where, or how, we're going to be experiencing it within payer enrollment. So our roles as MSPs, kind of like the new competency, and within our organizations as a whole, it's become the focal point, and it's where most processes and improvements are needed nowadays. And it's because of that, because of the change. Nobody knows where we belong. Nobody knows where payer enrollment should exist, should sit. Should it sit with credentialing? Should it sit with finance? Should it sit with revenue cycle? Should it sit with operations? And that's where the change control is needed within an organization, because the leakage is evident and it's almost immediate. It's almost immediate where the patient, enters the organization. When a patient calls a health plan, they're already going to know somebody is not enrolled because they're not coming up on a directory. So that means somebody didn't do their job, or that enrollment process did not happen correctly. So there's already a gap in that service. So as gatekeepers to the revenue cycle, without a successful payer enrollment process, sustainable revenue is not attainable. As an example, provider A starts on day one. Kind of draw this out in your head. Provider A starts on day one. Enrollment is notified with only 2 weeks of lead time. This is probably standard in a lot of different organizations. Operations tend to not really understand what kind of lead time health plans need for enrollment. So you get 2 weeks. Applications to a non-delegated health plan are submitted within 1 week of notification, but it takes 60 days in a good period to enroll. The organization can lose up to $250,000 and 320 hours of service by provider. So figure that. How many patients can they see in 320 hours of service? So that's a lot of money that organization is losing per provider. That's kind of that's the leakage that these organizations are seeing. That's the leakage that's surmounting on a daily basis, on a monthly basis, on an annual basis, and that's what's out there, and that's what these larger health systems are seeing, and that's what's coming up annually for them. And in hindsight, that's what all of these investment groups that are trying to merge and acquire these organizations are trying to stop. So when a process
Larry,
go ahead. Yeah, sure.
Excuse me, Larry. It's sort of like the squeeze, and I'm talking primarily about hospital administrators. They're getting the squeeze from the government because they are telling hospital administrators that your reimbursable dollars are going to be based upon how your organization and practitioners perform. Then on the other side, right, there's the health plan and how well they're going to be able to reimburse these providers based upon how efficient the process is from beginning to end. So that's the challenge that healthcare administrators are living with every day. Things, like I said, revenue cycle management was something that I never thought that an MSP who kind of has their background more so in the credentialing verification piece would ever have to know. But now we want to be at the table having these conversations with administrators and medical staff leaders, because whether they're working in a hospital, these same realities exist in their practice setting as well.
And it's the challenge that, the hospital or the organization administrators have the squeeze, like you mentioned. It's the understanding of their goals, and it's the understanding of our process, and what needs to happen to get there. It's that happy medium that needs to happen in order to get there, that needs to take place so we can make it happen. A lot of times when you're sitting in a C-suite, the understanding is not there, and it's where people are not on the same playing, or what do you call it, the level playing field, where there's a lot of misunderstandings, and that's where the leakage happens. So when a process is not in place, when you don't have all the stakeholders there, you don't have control over the time frames. You're getting people with no consideration for time frames. People will tell you at the last minute. People will tell you with a week ahead of time. You don't have control over your time frames, and providers are submitting incorrect paperwork, incomplete paperwork. That is probably one of the larger kickbacks in a health plan enrollment errors is providers submitting incorrect paperwork. You have miscommunication of information, whether it be an incorrect address, whether it be a wrong location, whether it be wrong data. You have no measurable metrics. You have lack of quality. Claim processing skyrockets and denial rates. You have aged AR, in other words, account receivables are rising, and health plan reconciliation due to rushing of onboarding. You're trying to rush all these people in onboarding, and you're missing things. Providers are being missed because you're trying to enroll a whole roster at once. So, if you're enrolling a roster of 300 providers, you're going to miss one or two. Then you have process inefficiencies because you're just trying to do so much at one time, and that's just going to create a lot of non-value added waste, which basically results to duplicative work, basically doing 2 times the work instead of when you can just do it once and do it correctly. Next slide. So what do we do? What do we do to kind of prevent that, to kind of, look at it, take a look at it, and be on the road to kind of mitigate it? So there's a couple of steps that we kind of want to look at it and kind of really break it out. And what I've done is I put them into 3 steps, and they're pretty standard across the system of management. And it's assess, plan, and execute. So you really want to assess your work area. You want to assess the process and break it down. You want to break down the weaknesses in the workflows and identify the steps that are needing to be refined, redesigned due to the gaps and or the efficiencies. You want to list them out. You want to work with the right people. Then you want to plan out a flow step by step and ensure each item is covered, being sure to itemize the full process, draw it out. You want to really, really look at it and kind of pick it out and really, really look at it to make sure, because this is going to ensure the foolproof, clean workflow. You're going to really draw it out A through Z, and then you're going to execute it. You execute the strategy by setting short goals with yourself and the team, because it's not going to work if you don't execute it. And then you don't really try it out, and that's where you're going to start making the kinks. You're going to start making the tweaks. Take each step of your new process and work through them, implementing one step at a time through until the full process is implemented. And it's not going to be perfect the first time. You're going to make tweaks. You're going to fix it. Something's not going to work. You're going to tweak it the next time, and then it's going to work. Then something else is going to need to be fixed, and that it's a continuous quality spectrum. So you're going to be continuously fixing because everything is different and it's always going to change. So
Larry, when you look at this 3-stepped process, right? Assess, plan, execute. That sounds simple enough. Oh, okay, yes. But I know that there's lots of moving parts behind each of these 3 steps. And yes. How does one begin that process without feeling overwhelmed? Do we reveal the next slide? Because in the assessment phase, that sort of helps it kind of be broken down into more manageable parts.
Yes. Let's go to the next slide, because then we explain them out on the for the assess feature or the assess steps. Basically, this is where we, like I said, take a deep dive into the process. There's a few terms that I've learned across my career, especially with a lot of the newer process management techniques, is there's what's considered a Gemba walk. You actually review the process by walking through step by step from one end through the other. You're literally sitting there processing a file, in other words, in an enrollment process or in a credentialing process, and you're writing it down. Or it's kind of what they do if you remember through in an assembly line at a car plant. You're watching it as they assemble a car. And you're documenting the full process. What this does, it allows you to see how many steps it takes you to get from point A to point Z. Then you're going to be able to identify every single step that it's taking you. And you're going to see all of the hiccups and all of the non-value added pieces to it. And you're also going to be able to point out the non-biased, and then you're going to need to be non-biased about it, and also you're going to have full disclosure. In other words, you're going to need to really be honest about it. There's a lot of times that say, "Oh, I don't need to put that in there. I don't need to cover that. I don't need to list that out just because it's something easy to do." It takes 2 clicks. You need to write down 2 clicks. It takes, I need to walk over here 18 steps, or I need to go and talk to somebody. I already know he's going to say yes. That's another process. That's another step in the process, because that person may not be there in a month or 2 months. Those are hiccups that can really hinder a full revenue cycle process. That can also create another revenue leakage later on down the road. So we really focus on no shortcuts, and that's really going to help you truly assess a full workflow. Another item is what they call a SWOT or an SBAR of the process, and what that does, it helps you kind of write things out. It's not so detailed as a Gemba walk, but it lists out the weaknesses, the strengths of the process steps, and gives a full depiction, kind of an out-of-the-box image of the process, and it helps visualize the impact. It's the kind of an at a glance view. It's a 4-box one sheet, and it's strengths, weaknesses, and impacts. And basically, what it does is it kind of gives you a review of your process, and then it also provides recommendations. And this is what you would do for leadership, and so that you can provide your own recommendations on what you want to do in order to implement a new process. This is what happens when you want to implement new software, when you want to implement possibly a new full-time employee. And this is also what you want to do when you want to work with some stakeholders, because it is important to get more people involved. More people involved in the process is going to help you communicate your ideas better, and also to help you get outside views of what's going on in your own department. Provider enrollment and revenue cycle is not you sitting in your desk working a file. It's actually you being in enrollment really touches a lot of different departments, because you're going to be touching revenue cycle, you're touching claims, patient interaction, also finance. So all of that through until somebody gets paid, it's all controlled by the enrollment specialist pretty much. And that's the reason why I say that we are the gatekeepers to revenue cycle. So there is a lot to do with the provider enrollment experience. And that's why anytime all the way from recruiting a physician all the way through, we can make sure that the provider is enrolled. We need to make sure we include all those stakeholders that are included. So the stakeholder customer satisfaction is key.
And Larry, when we're talking about this phase, have you seen this process be successful with a frontline staff person doing this assessment, or does it require more executive leadership or a supervisory role to kind of work with the frontline staff, the people who actually do the work?
So I've seen it done on three different levels. I've seen it done at a leadership level where leaders would get together in different departments, like I said, on a leadership level, and then they would brainstorm their own ideas on how the process should work. And then I've also seen it done on a mid-level workflow level where they would get together on how those processes should work, and then on the frontline level within those departments. And then they do all end up working together because they will all intertwine workflows. So,
Okay.
there really is no barriers in terms of which, you don't need to be in a leadership role in order to make an impact in a workflow or make an impact in efficiencies. There's a lot of benefit in in identifying these types of efficiencies in your processes, because what happens is that it does create positive changes, and it creates a lot of satisfaction on the end of the customer and on the end of the process as a whole.
Okay, then
You'll
just
notice
one other
that's
question. I'm
sure.
sorry, go ahead.
No. Go ahead.
Okay. Then one other question regarding that. Are there certain expressions that a supervisor or an executive leader would say to a frontline staff, or is this leakage? Is this something that the frontline staff person would be knowledgeable about, or is it that they're getting pushback from the boss saying, "Hey, we have to turn these things around faster. We have to." And why I'm asking that question, as a frontline staff person who actually is doing the payer enrollment work, are there things that they may be hearing from their supervisors that's kind of alerting them that, hey, we need to really walk through and do this assessment that maybe the boss isn't really, it's kind of like not on their radar screen, that we can begin the conversation?
That's a great question. I think on a frontline staff perspective, I think being in that role, I think that is probably where they would notice it more, is that doing the actual work, they would know where efficiencies can happen on a better level. They would know where duplicative efforts would fit when they're being contacted, or actually they're contacting a provider multiple times for the same document, or they're contacting too many departments at once, or they're seeing too many of the same types of questions come through when it can be answered one separate way, or they're seeing too many types of denials come through, or one type of health plan, realizing that that particular organization is not contracted, when they can kind of redirect that patient to another area. So I definitely think that the front line in an organization probably has a better sight into a lot of the inefficiencies in an organization, whether it be from the administration. The administration probably has the oversight and really probably won't hear anything until it gets to a higher level, or until it gets to something where it's probably already at a level where the control is a little bit overbearing at that point.
And that's why I asked the question, because oftentimes there are our colleagues who feel that they don't have a voice, that what their experience is, it's not going to make a difference. But this is where we could really step up to the plate, right, and point out, hey, there's some efficiencies in this process. Let's begin in the assessment phase.
Quite the opposite. I am 100% on the opposite realm of that. I completely agree with any level of staff taking initiative in their own process and making sure that they're actually taking ownership of their own process and looking where efficiencies can happen, because we can all benefit on our own process and work through it.
Got it. Okay.
And definitely feel empowered. We should all feel empowered in our own roles, because we all have great knowledge to offer. Being MSPs, there's a lot of people that rely on what we do and our knowledge base, because there's especially in these types of roles with provider enrollment, with revenue cycle, with credentialing, with medical staffing, there's a lot of people outside of our industry that rely on us and the information that we have, and that the knowledge base that we hold. So definitely use it to our advantage. The next step would be, after assessing, would be planning and kind of working through the big picture items, and really this is where you kind of draw it out and make sure, you get the time frames from recruiting to clinic start date. That's kind of using the organization in a recruiting perspective. In a non-delegated environment, you kind of realize that the plan sets its time frame, not you, not the department. They can't blame you because you don't enroll a person on time. It's really not you that sets the time frame. You have to set that culture too. A provider enrollment specialist should also be empowered enough to help set that culture. It's a lot of times that the time frames are set externally. So you want to make sure that working with those stakeholders, you create that timeline that's going to help build that in there. So when you're drawing this out, working with the big picture, you consolidate it with all of your stakeholders. You're going to be working with recruiting. That's the time that they're starting to go to look out for providers, because all of that's going to matter. And that's where we come into looking for what information that's needed, how many departments that we're going to be needing information for, all the way down to how many applications are going to be submitted, what health plans they're going to be enrolled in which areas that your organization is based, I already said what health plans, but if you're delegated and non-delegated, because that's going to matter on which plans that you're going to be submitting to, and then also the time frames. And then you're going to, probably one of the best practices is consolidating it all into one process. Working with all of those stakeholders, it's going to help you do that. It's going to help you really consolidate the workflow. I can't speak enough on a lot of the presentations that I've given. I had probably the most enriching experience working at University of California, San Diego. I was fortunate enough to take part in a rapid process improvement workflow. They helped us get together a whole bunch of stakeholders. I was one of them, and we got a whole bunch of departments together for a week. I hesitate to say, but they closed us up in a room for 8 hours a day, and we all kind of hashed out the workflow process for onboarding. And there were over 100 plus touch points for a physician that we did, from onboarding, from recruiting all the way through their first clinic start date. And there were 100 plus. We used to request information from providers multiple times, a CB probably 4, 5, 6, 8 times within 6 or 8 months. And, it all got consolidated down. We put all of the application process down. Our enrollment team was able to consolidate a paper app. We went online. We were able to get access to one of their credentialing software systems by, working with their credentialing departments. So, there's a lot of improvements made, and it was all done because of collaboration with the teams. So it's definitely doable. It's definitely, worth the effort. Collaboration is necessary, and, working with the stakeholders in processing, just keeping everybody apprised of the changes in the workflow. And it's kind of why underlying transparency builds confidence. When people really know what's going on, it kind of helps build the confidence, and people will stop asking, people will stop wondering what's going on in your department, especially when they're not understanding what we do as MSPs or as credentialing specialists, as pay enrollment specialists, except push paper a lot of times, which is the understood job description. But Transparency builds confidence. The more you're transparent, then they stop asking, and they start really respecting what we do and understanding our process. So in the planning phase, at the end of your planning phase, you're going to have your process built out A through Z. It's going to be a large workflow, but it's going to be really clean. It's going to have steps, all the way from start to finish. And you're going to be a really clean and a very succinct process. And you're going to see at this point all of the leaks that you would have had, and you're going to be able to have already worked through them and already know that we didn't need to have marketing. We didn't need to have the clinic reach out to the provider the additional time, because we could have gotten that we could have gotten that all at that one time in the very beginning. So all of those types of leaks would have delayed the application another extra day, which would have delayed enrollment, which would have delayed, the provider start date. So those are the things that can kind of all add up to any type of delay in revenue. And that's what the organization at the very end does not want. So we're all working up to that major goal, which is the delay in revenue, or a ultimate denial, which is definitely what we don't want. So once all the planning is done, we've assessed, we've planned, now we're ready to execute. Put all the work together, ready to test it. This is where the work begins, testing the process one test item at a time. Work through step A all the way through step Z, and to show how the process works. You continue to analyze it every single day, and this is basically just doing the work on a daily basis. It's going to change. Not every file is the same. You're going to work through it. You're going to work and just to see how it's working. You've built out your workflow. You've done all of the assessing. You've done all of the planning. You don't want your work to go to waste. So you want to make sure that your workflow is working for you and working for all the stakeholders that put all that work into it. So you just want to continue to just refine the process as it goes along, because all of that work put together is to make sure that everything is tweaked and everything is refined in order to make sure that that revenue continues to flow and continues to flow as soon as the provider gets their effective date. And in the end is just tracking and reporting, and that's going to allow you to track your performance and trend your success. Basically, at the end of the day, track your performance. How many days did it take you to enroll that provider? What we do here is basically the day that we submit an application for our non-delegated health plans, we document the day that we submitted the application, and then we document the day that we received the effective date. No matter if the health plan gives us a retroactive date, no matter what date that is, that's the date that we completed that enrollment. It could be 90 days, it could be 180 days, but that's the date that it took that health plan to enroll that provider. That's how we track our performance for that. And then we also trend the success. So then it helps us to know and gives us an average of how many days it's taking us to enroll a provider for a particular region. So, for us here at U.S. Dermatology Partners, we know that in our Mid-Atlantic region, it's taking us a little longer than about 95 days to enroll a provider for our non-delegated health plans. Here in Texas, because we're delegated mostly, it's taking us about 33 days. So we're doing okay. Last year, it was taking us about 160 days. So now we're doing good. And that's why I say it's a continuous quality improvement. It's the constant in our lexicon. Our industry changes with climate of healthcare, so our workflows must change with the industry. And that's going to be a constant. We're always going to change. We cannot get in our silos and just accept that this is the way it's going to be. We just really need to kind of, the old cliche, go with the flow, and continue just with the process, because payer enrollment, just like with our healthcare industry, how IPAs pop up in all of our 50 states, and mergers and acquisitions happen in our health systems, We have different specialties coming up. There's different requirements now required for payer enrollment. In credentialing, just with our recent pandemic, we've had our, what are they called, Donna? Emergency privileges having to be executed.
Mm-hmm.
A lot of us weren't expecting those. So, and a lot of that really truly affected enrollment, and we're going to be experiencing a lot of pains and a lot of growing pains when the waivers expire, when the declaration expires. So, and that's coming up. We don't know when yet, but it will. So a lot of that takes a lot of planning. So next up for our last few minutes is our 4 process improvements in peri-enrollment workflow. So there's a few process improvements kind of going through the workflow in 4 steps. We kind of broke it down. There's a lot more steps, and we all know that, other than the 4. So breaking it down, the first step is our info gathering phase, where we kind of just gather it all from the provider or the organization to ensure correct enrollment. Then we provide and ensure accurate data submission to the payer. Then the follow-up phase, which is probably the longest and most frustrating. And then we also get the welcome letter and participation effective date. And that's so literally processes number 1 and 4 are the important ones for your tracking and your trending. Next slide.
Before you advance, the stage
Sure.
number 3, the follow-up, you're right,
Yes.
Larry, when we give presentations across the country, and I want to say in particular over the last couple of conferences for NAMS, audience members, they want to try to help improve the process, but invariably there are such frustrations with step 3, with people at the health plans even answering their phone, or when the MSP leaves a voicemail message, it just falls into some black hole and no one ever gets any call backs. Have you noticed that problem increasing because of the pandemic? It's even worse than it was before.
So it's been I've seen both situations. Because of the pandemic, we've had increase in communication because our provider reps have been in the office more. So it's been actually a little bit more positive. But it's kind of twofold. What we've tried to do with follow-ups, we do spread them out over about every 2 weeks, especially for our non-delegated, our payers. But we do try and we do understand. I have been fortunate enough in my career to work in the health plan side, so I do understand the clinic side and wanting to know what's going on. And so I also know how the payer feels that, you're not the only one that I'm working, kind of thing, that mentality. But a lot more health plans are resorting to a template response and just saying that your application is in process, or they're resorting to a ticketed response, or they're resorting to a templated email. But as long as you ensure every 2 weeks you have something documented, I think that's extremely important. Because when it comes down to the time where you're getting to a milestone date, which I'm considering a milestone date, like at your 30 or your 60 or your 90 days, those documented timeframes or those documented calls and emails are important, because you would want to put those in those milestone communications. I've contacted you on X day, X day, X day, and I have not heard back from you. I need a response. I hesitate to tell you to not document any communication or to not call back, even though you know that it takes 90 days. Still continue to follow up, because applications do get lost and they will get lost. So there's a couple of improvements that we listed out that I do like to kind of reiterate across the board, and it's kind of just reiterating about data governance. There is a really important kind of element here, and it's just kind of data governance plays a really important role in pay enrollment. CMS kind of did a review, and I got this study that CMS did a review of 54 organizations, and they revealed that 45% of the directories contain inaccuracies, such as a provider not being located at the address, incorrect phone numbers, erroneous information on whether providers were accepting new patients. So causes for provider organizations end up referring patients to out-of-network physicians and missing out on potential revenue stream. That happens all the time. CMS is cracking down on the health plan organizations, which definitely will fall down onto the provider offices. What's happening is that they're calling randomly to provider clinics and they're trying to schedule appointments. What we've done in the past to schedule or to enroll patients just because to enroll providers, it was a best practice years ago because providers used to move around a lot. We used to enroll providers in many locations at the same time because it would take so long. Well, CMS doesn't like that. And what's happening is that they're calling all these provider locations and they're finding out providers don't work there, or office staff has had so much turnover, they're finding those providers are not even known, or those office staff members have never heard of that provider. So what they're doing is they're either telling the health plan organization that provider doesn't work there and to term, or they're telling them to notify the organization that the provider is not working there to find out what's going on. And then they can end up in putting a corrective action out and having us to update our directories. So, be mindful of how things are being enrolled, because that will end up having issues with revenue, and it does allow for physicians to be not referring to correct physicians, and that's going to definitely affect revenue. Nothing is more frustrating than one of your physicians having to refer to somebody outside of their network. That's extremely frustrating. So creating one source of truth using a single technology source creates a strong base for directory support. Usually in an organization that has adopted a single source of technology is great. And then actually using it as a single source of information, all the departments using it, that's extremely helpful. And that's probably the best practice that I can't preach. I can't preach enough, just because that means everybody has vested interest in it, making sure that it's always going to be accurate, making sure human resources, making sure marketing, making sure credentialing and provider enrollment are all going to have the most accurate data in that one system. And that's what you want to really, really strive for. It can be used at the organizational level to assist with enrollments, reporting, and dashboard viewing with performance, because that can also be reported at the C level. So that's always going to be helpful if you really, really strive for that and make that into the culture. And then consolidation of efforts works best when collaborating with multiple stakeholders and brainstorming all the ideas. That's kind of like what we mentioned during the process phase. During the planning phase. It's application gathering, documentation, document sharing in that one singular portal, in that one singular system. Most systems nowadays, especially like simpler, it's document holding. You can share all your documents. There's usually some securities that can be implemented where documents can be shared between users. So it's definitely something that would be worth looking at. Application gathering is sharing between credentialing and enrollment. Just out of the top of my head, that would be probably the most effective. There's also documents that are shared between human resources and shared between marketing and your clinical operations teams. There's also securities that would need to be definitely discussed between compliance and credentialing, but those are definitely something that's always been questioned, and definitely something that can be addressed with the software programs. And then delegation, you should reach out to your health plan. Delegation is the easiest no, I shouldn't say the easiest. Delegation is the best and most effective way to mitigate your revenue and your enrollment, because it will cut down on provider enrollment timeframes significantly. You control your timeframes, and you control your credentialing process and your timeframes and your quality. So you should reach out to the health plan if you're not delegated and check the provider count requirements, their minimum requirements. Usually it's going to be NCQA standards that you would need to follow. Credentialing program and committee requirements that you should be able to have, also your quarterly, monthly reporting requirements. So reach out to your health plans that you don't have delegation with and request your new partnership with delegated credentialing under your current contracts. We were able to do that here in Texas, and we've been pretty successful. So we cut down we cut down our time frame almost 53% over the last year. So it's been very, very, very successful for us.
So the information that Larry has done such a good job outlining really allows you all to consider, definitely, but by taking the lead. We're planting seeds for you on what can be done to improve this revenue, this money delay in getting into your organizations, into your providers, by attending programs like this and being able to offer some process improvement initiatives to your supervisors and executive teams that you want to be a part of those experiences, and then just continue to work on making a difference in your organizations, because every step that you're taking really is changing things just a bit. We see the landscape of how healthcare is changing, and we want you as MSP professionals, payer enrollment credentialing, to really be taking the lead and being at the table when discussions are being held. So with that, just a friendly reminder in the couple minutes that we have remaining, and I know Steph will gather any questions perhaps that have been entered during this program, but Nicole and I will be presenting next month's webinar on practitioner competence. And for those of you who've heard Nicole speak before, she's really the guru on healthcare quality and physician quality. So it will be very much of an informative experience. So with that, I'm going to turn this over to Steph with any questions, or for her to provide any kind of information she would like to on behalf of Simpler.
Thanks, Donna. If you don't mind, go ahead and advancing the slide. Thank you. So we'll stay here. If you're struggling to keep up with your primary source verification or payer enrollment needs, our team is here to save the day. Reach out to Simpler CVO for fast, accurate, scalable credentialing and enrollment services. And there's a bonus. We can work in any provider credentialing software platform, so it's easy for you and your team to track along with our progress. Get in touch today at hello@simpler.com. And then if you wouldn't mind advancing, Donna, we will go ahead to the Q&A. We do have several questions, and I know we are going to be over time, so we'll probably lose some folks, but one of our questions is, do you have any advice for delegation in the teleradiology industry?
Larry, you want to
Sure. What I would do with that is I would reach out to your health plan payers that you're contracted with for teleradiology, and bring it up and see if they're interested in partnering with you. Usually they are not, they're definitely willing to, they're more concerned about the number of radiologists and then the areas. I think it's more concerning about the areas of service. So it definitely would be something that they would be interested in. I know I've heard about it. I have not experienced or have had experience in it yet, but not particularly for teleradiology specifically, no. But definitely reach out to the different payers for that.
Great, thank you. Another one is, how do you best deal with the overwhelming amount of time spent on updating provider directories? Even after providing updates, the directories remain outdated.
Yes, it is sometimes very frustrating when you are updating it quarterly and it seems like it's weekly, but it is constant. That is the reason why one of the best practices is delegation, because a lot of times it's on a monthly basis and you do it through the payer rather than through these portals. Working with the payer a lot helps, but it's kind of scheduling time and having to work through it on a team, kind of really working team in a team effort. But it is necessary because things do get outdated and it's constant. And unfortunately, it's one of those things that is becoming more and more necessary. I know there's a lot of services out there now with, not to name drop, but there's Availity. There's a lot of different services that are those clearinghouses that are offering, that are working with the health plans, actually, I should say, that are utilizing directory assistance. So definitely if you can use those, because they're grouping up with a lot of different health plans, that can help you kind of minimize having to do it one by one.
Great. Another question is, when using a single source of truth, how do you reconcile provider data that may be used differently from different departments? Example, phone number for provider. Do you list the primary practice location number or the provider's contact number or credentialing contact?
So when you're, excuse me, in a payer level, when you're at a payer level, what they need to have is the customer. Anytime a payer, when you're doing enrollment, what you're enrolling is the payer for patient contact. So at the payer level, what you need to put in there is what the patient number is going to use. So it's going to be an outward contact number. So it's going to be at the what you call it, the clinic number. Now, on a credentialing, when they have a credentialing contact, and that would be your number, you would never put a direct provider number in there. I would not recommend you putting a direct provider contact number into a provider application on a health plan application, because they'll end up having a patient call a provider directly.
Mm-hmm. I would agree with that, and I'm not as familiar with payer enrollment databases, and I know that there's shared information that can be used from the credentialing side as well as the enrollment side, but does the payer software allow for a different contact source than the credentialing side?
Sometimes it does. You really need to delve into the specific payer and on the application, what the application field is asking. If they're state-specific applications, that's where you run into a little bit of challenge because of the payer is so different within their system. We have run into a challenge with that on several payers where they're only allowing for one particular contact. But when that happens, we put in one of our main numbers that we use. We try to protect the provider from any type of personal information going out as possible.
Yeah.
Because
and Larry,
it will happen.
Go ahead.
Go ahead. No, I was saying it will happen where a provider's personal contact information can get out, and we want to make sure that's protected as much as possible.
Sure. From a credentialing side, I know that there is no universal way. What I find when I'm in the field is that every organization or health system makes a determination of how they're going to use that contact information. So, I think that that's kind of where some of the confusion lies as well. But truly, on the credentialing side, we want to protect that doctor's information as well. We don't want unnecessary calls or texts going to our physicians.
Right. I mean, there's a lot of times where health systems have one patient contact number or an appointment line. That would be probably the preferable to use for a provider directory that's an online directory, or a specific site number, a clinic number, something that would be able to, whatever I think about that's going on a provider application for a health plan, it's something that's going to be printed on a public website, because it's going to be something that's going to be available on Google. So you don't want anything that's going to be like a cell phone number or something that's going to be accessible to them directly.
Great. And since we are over time, I'm going to do one more
Okay.
question, and then perhaps we could do some direct follow-up to these people that had some questions.
Sure.
Our last question is, what is the best way to deal with those unrealistic start dates?
Unrealistic start date, a lot of it's, again, transparency builds confidence. So communication from the get-go, letting them know that health plans take X number of days. In my experience, such and such health plan has taken X number of days to enroll this provider. We can help. We can do our best to get them enrolled in this amount of time. However, this is what's going to need to happen. Provide a solution-based resolution. A lot of, like I said, transparency builds confidence. So, offer solutions, but definitely be upfront about it, and let them know this is what your experience has been, and just be upfront about it.
That is a challenging one, though, because
it is.
Because administrators don't always understand, well, they frequently don't understand the process. So their expectation is much higher than the reality of what we as MSPs have to work within. So again, it's always educating, right? We're educators to our medical staff and administrative teams, because we're the experts doing the work. Now the next piece is that we want them to hear with a different style, so they really absorb. When we're saying it takes 90 days, we're not fibbing. It really does take that length of time.
It is. But the culture will change, and people will understand. And again, transparency builds confidence, and the people will be confident because we are the experts, and people do look to us for those responses and those answers.
All right. Well, just a final reminder that we will be emailing all of the attendees today with a webinar link to download this presentation, as well as the slides that were shared during today's presentation. You'll also get a copy of the NAMS CEU certificate as well. So thank you so much, Donna and Larry, and everyone here on the webinar. Don't forget to add Simpler to your inbox to ensure you're receiving communication. We'll see you all next time, and have a wonderful weekend.